tomorrow because I'm boycotting it. Don't really care about Kansas City or the Buccaneers. What I'm not going to be boycotting is continuing to learn about appropriate coding and billing using E&M 2021 rules. So today I'm going to talk about something that's kind of perplexed me for a little bit in the last month and a half or so since implementing E&M 2021, and that is active surveillance for prostate cancer a level 2, 3, or a 4 E&M visit? And the answer, TLDR, is it depends. And I'm going to give you some concrete examples of what's possibly a 2, 3, or 4. First of all, my name is John Lin. I'm a urologist in Gilbert, Arizona. Also, your humble host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions so that you can live a more fulfilled and productive practice life. All right. I am not the only one running this group. I have to give thanks to my moderators, Danielle Freeman, Dr. Pullman, Dr. Casperson, and Karen Brown for moderating this almost 1,300 member group. So let's talk about this active surveillance and prostate cancer. Typically, it's an older man who comes in and you've already diagnosed him with some sort of prostate cancer, and the patient has decided, you and the patient have undergone decision-making and are continuing him on active surveillance. So the patient typically comes in for follow-up, and you are looking at a PSA that you most likely ordered some time ago, several months ago, possibly. And the patient comes back and everything is okay, and you just kind of follow up with the patient. So is that a level 2, 3, or 4? We're going to go into that in just a second. First of all, we need to understand medical decision-making, because E&M level in 2021 is based on medical decision-making. Typically, the problem is a chronic that is stable or chronic with exacerbation. One is a 3 and the other is a 4. So chronic stable is a 3, chronic with exacerbations a 4. Everything comes down to the risk section when you are trying to determine the level for an active surveillance prostate cancer patient. So risk, we are so used to the, let's see, this table right here. I will just show you what I have. This is the wall chart from the painters. We're so used to looking at this wall chart and looking at the risk and looking at the AMA risks without realizing that there's more than the examples that are given in the wall chart and the AMA table. Those are just examples. More examples of diagnostic tests and also the surgery and the procedures that we may order and the labs that we may order, but there's a big part of risk that is not typically covered or discussed, and that may play a role in what's a level 2 or 3. Let's turn to the source. So don't take my word for it. Always go to the source. This is the CPT E&M office and other outpatient and prolonged services codes and guideline changes published by the AMA effective January 1, 2021. On page 5, and I bring your attention to the risk section. This is on page 5. And this is how you determine risk. And this is ultimately how you are going to determine the level of your E&M service when it comes to this active surveillance prostate cancer. So the risk, and I'll read this, the probability and or consequences of an event. The assessment of the level of risk is affected by the nature of the event under consideration. And this is very important. I need you to pay attention to this section. For example, a low probability of death may be high risk, whereas a high chance of a minor self-limited adverse effect or treatment may be low risk. So let me read that again. For example, a low probability of death may be high risk, whereas a high chance of a minor self-limited adverse effect of treatment may be low risk. So we need to keep that in mind as we go through this part. Okay, back to the definition. Definitions of risk are based upon the usual behavior and thought processes of a physician or other qualified healthcare professional in the same specialty. Basically, how you determine risk is ultimately going to be judged by a group of your peers, if it comes down to that. Okay, back to the definition. Trained clinicians apply common language usage, meaning to terms such as high, medium, low, or minimal risk, and do not require qualification for these definitions, though quantification may be provided when evidence-based medicine has established probabilities. For the purposes of medical decision-making, level of risk is based upon consequences of the problems addressed at the encounter when appropriately treated. Risk also includes medical decision-making related to the need to initiate or forego further testing, treatment, and or hospitalization. So it's a mouthful of a paragraph, but everything that you need to know in considering risk in medical decision-making is beautifully summarized in that paragraph. And when it comes to medical decision-making, when it comes to risk determination relative to active surveillance for prostate cancer, you will be smart to use that paragraph to guide you on how to determine your final E&M level. So let's take some examples. I don't like to just throw out these guidelines without giving you some concrete examples. And let me know if you agree, disagree, or what your thought processes are. I know we all want concrete examples from the AMA CPT panel to guide us on how to code our E&M levels. Unfortunately, the AMA fortunately, the AMA CPT panel deliberately made this kind of ambiguous and is subject to interpretation. And it is up to us to use the guidelines to apply these guidelines to determine the ultimate E&M level. Some of your compliance officers may be misled, so you may have to explain to your compliance officers why they may be wrong, because often they're not clinicians and they don't really know the nuances of clinical medical decision making. Now, that said, it is, and this is going to be a recurrent theme, I've said this over and over again, the main thing for clinicians is your ability to convey the nuances of that visit and why this is a level 2, 3, or 4 visit in your clinical documentation. So once again, your documentation is going to drive your ultimate E&M level and justify it when you are in front of your peers or when you are under scrutiny from the payers when it comes to audits. Let me give you some examples of possibly a level 2 E&M active surveillance prostate cancer patient. And again, if you have any questions or comments, please leave them below and I will try to answer them as best as I can. All right, so let's just say that this is a typical 77-year-old with a Gleason 6 prostate cancer with a stable PSA that you're seeing him back 6 months after you ordered a PSA. So stable PSA with a PSA that you've been following, and it's rock stable, Gleason 6. The patient's clinically asymptomatic, no weight loss, no anorexia, no unusual aches or pains that he is complaining about. Great urination, which is a separate problem that you may be able to address. But let's concentrate on prostate cancer. Clinically asymptomatic, stable PSA, and you just say, hey, you know what, Mr. Jones, you're doing great. We're just going to check another PSA in 6 months because the chances of this cancer harming you and leading you to die from this prostate cancer is currently very low. And you and the patient come up with that same decision. And so the risk in this situation, in this example, I believe is a low risk type of visit. You simply check a PSA, patient's doing great. You order another PSA for the next 6 months. So that's a stable problem. So that's a level 3 risk on the problem section. And for medical decision making is minimal risk. So this will be a 99212 level 2 E&M visit. So let me know what you think. Let me know if you agree or disagree with my assessment. Let's go on to a level 3. Same type of prostate cancer patient, 65 years old or 77-year-old, however you want it. It doesn't matter. Gleason, now in this case, this is a Gleason 3+4 with multiple cores that were positive, and the patient decided to undergo active surveillance. At the initial diagnosis, his Polaris genomic test was positive, recommending single modality treatment, but the patient decided to undergo active surveillance. And also, the PSA is stable at this time. So the patient's also clinically asymptomatic, but you tell the patient that, hey, you know what, you have a moderate risk disease, and I think that you should consider some sort of treatment. However, the patient decides, hey, you know what, I'm just going to continue with active surveillance. Clinically, I'm great. Biochemically, PSA is rock stable, so I'm going to simply continue. But you are having a discussion with the patient that, hey, there's a chance of you being harmed by this prostate cancer, and that chance is not insignificant. And you document that. The most important thing is you document that in your chart. And you don't have to be writing a novel. You can simply say, clinically, intermediate risk prostate cancer, Gleason 7, stable PSA, clinically no evidence of progression. However, I am worried about this patient given the risk factor and the positive genomic test. Instead of checking PSA every 6 months, you decide to check a PSA in 3 months. So you briefly document that in 2 to 3 sentences. And now this is, in my opinion, this is a level 3 risk, because this is not an insignificant, it is not a minor type of a risk that you're just doing the typical active surveillance. This is more of a intermediate risk patient with potential harm that could be done to the patient by not following him closely. So I think that's an intermediate risk cancer, and this is a 99213 type of a visit. Okay, let me know what you think. Agree, disagree, let me know in the comments. So say this is a different patient who also has Gleason 3+4, multiple course positive, with a family history of prostate cancer, who's also African American, with a rising PSA, known history of positive Polaris genomic tests, recommending a single modality treatment, and patient remains asymptomatic, but the PSA is rising. So now, instead of a chronic stable problem, you probably have a chronic problem with progression. In the problem section, that's going to be a level 4 risk. Now, level 4 problem, excuse me. So now let's go to the risk section. So this is a patient with family history who's also African American, with rising PSA, with intermediate risk prostate cancer, known history of positive Polaris genomic tests. What do you think should be the risk level for this patient? I personally think that this is a level 4 risk, because it is not, you're just kind of watching the PSA and everything's fine. No, there appears to be disease progression, and there's a significant risk of harm to this patient. Once again, I bring your attention back to this page 5 of the CPT Evaluation and Management Guideline from the AMA, effective 1/1/2021. So for the purposes of medical decision-making, level risk is based on the consequences of the problems addressed at the encounter when appropriately treated. Risk also includes medical decision-making related to the need to initiate or forego further testing, treatment, and or hospitalization. So yes, we like to pigeonhole every single risk that we see for the patient into one of the examples by the AMA on the risk table. Unfortunately, that is just not going to happen, because you're dealing with humans with tons of variability. So it's really incumbent up on us, the clinicians, who will need a little bit of understanding of the language of coding and billing to help with our documentation, and also help the auditors and also help our coders. If you're not the person coding, if you're relying on somebody else to abstract from your documentation, it will be up to us, the clinicians, to write down your thought process so that the coders and the auditors, and ultimately a group of your peers, when we look at your chart, we can agree with you that you are justified in coding and billing for that E&M level. So anyway, that's what I think about this active surveillance prostate cancer. It is not just a straightforward level 2, and it's not just a level 3 or 4. It's nuanced. You have to explain your thought process as a clinician, and most importantly, write it down, document it. It does not have to be a novel. It could be just a very short, simple sentences. And to help with your documentation, I personally use voice recognition. I can talk about 140 to 160 words a minute. I type about 75 words a minute. But typing is a pain in the butt. I've been doing this for many, many years, and I've gotten tired of typing. Talking, I do every single day, and I do every single time that I see a patient, and I can convey my ideas much more quickly by talking. So I highly ask you to look at voice recognition if you don't have that. Some of our colleagues are using virtual assistants or scribes to make your lives easier so you don't burn out. Gosh knows that there's a shortage of urologists, and as I'm getting older, I need you all to keep working so one day I may need your services, right? All right, any comments, questions, concerns, please leave them below. As always, have a great weekend. Take care.